Welcome to Onc Now, the podcast where we explore the latest research, innovations, and clinical perspectives shaping the field of oncology. I'm your host for this episode, Dr. Catherine Glass, and today I'm honoured to be joined by Professor Nicolas Girard. Professor Girard is head of medical oncology at the Institut Curie, Paris, France, and a world-renowned expert in thoracic oncology. His work has significantly advanced our understanding and treatment of lung cancer. Welcome to the podcast, Professor Girard. It's a privilege to have you with us.
Thank you.
So, on to our questions. You've had a remarkable career in thoracic oncology, not a typical specialty to follow. What initially drew you to this field and what continues to inspire your research and clinical work today?
You know, when I was a resident and actually a medical student, I worked in respiratory medicine departments, and at that time, lung cancer was clearly an orphan disease with kind of old-fashioned treatments. Many patients not receiving any kind of systemic therapy. And when I started as a resident, actually, it was the time of the discovery of the EGFR mutations. So it was very enthusiastic to participate into this molecular biology discovery, the use of targeted agents, the stratification of patients, personalization of therapies. So it was clearly lung cancer was actually really appealing for many researchers, for clinicians, and we saw the survival of patients increasing with immunotherapy used in metastatic patients in the perioperative space. We are actually seeing patients now that are cured from their disease, which is obviously a major progress. So this is clearly my driver for continuing this research, not only basic research, but also clinical research.
Oh, fantastic. So, for our listeners who may be less familiar with thoracic oncology, could you give us sort of overall snapshot of the field, including the main types of lung cancer and the current standard of care treatment landscape?
Sure. So we have two major types of lung cancer: non-small cell lung cancer, 85% of the patients, and small cell lung cancer, 15% of the patients. Non-small cell lung cancer, we treat the patients based on stage, and we have three groups of patients: patients with a resectable disease who will go for surgery, patients with metastatic disease will go with systemic therapies, and in between, locally advanced lung cancer. In non-small cell lung cancer, we stratify the patients based on the presence of driver oncogenic mutations or alterations, which may predict the efficacy of targeted agents. So we have three groups of patients based on stage, and we have those two groups, patients with or without molecular alterations that predict the efficacy of targeted agents. On one side, we will treat the patient with targeted therapies in the case of molecular alterations in the perioperative space, after chemoradiotherapy, or in the metastatic setting as single agents or combined with chemo or with other agents. And on the other hand, for the patients without such molecular alterations, we go for immunotherapy, again, as exclusive treatment in combination with chemo for metastatic disease, but also in non-metastatic patients. Small cell has been an orphan disease with the same chemotherapy regimen for more than 30 years. And now we see new therapies, immunotherapy, but also T-cell engagers, bispecific antibodies, a lot of progress coming from these drugs. And for the first time, we had some positive phase 3 trials for the management of patients with metastatic small cell lung cancer. So the field is rapidly evolving. Immunotherapy, targeted agents, now the bispecific antibodies, antibody-drug conjugate, multiple biomarkers to stratify the patients. So it's becoming quite complex with multiple entities and personalized therapies that have to be implemented in the clinic.
That sounds very optimistic. So, looking at the clinical research a little bit more in lung cancer this past year, which trials do you believe are the most significant, and why might their findings change patient care?
Well, I think that small cell lung cancer with bispecific T-cell engager tarlatamab, the Delphi 304 trial, is a major trial in the field. Not only because for the first time we have a positive phase 3 trial in the second line setting for small cell lung cancer, and we have a major benefit in terms of overall survival for the patients. It is the first time that a bispecific T-cell engager antibody shows a benefit in solid cancers. It's widely used in hematology, but here it's in a solid cancer. It's a new era. We are already moving from second line to first line maintenance and combination with chemotherapy and immune checkpoint inhibitors. So yeah, Delphi 304 is probably one of the major trials reported in 2025.
Fantastic. And thinking about Institut Curie, for our listeners, could you share a snapshot of the current clinical trials and research initiatives you are leading at Institut Curie?
Sure. So actually, we have some trials that are ongoing and promoted by Institut Curie, focusing on the biomarkers. In patients with metastatic non-small cell lung cancer, we have the PD-L1 status that is predicting the outcomes of patients treated with immune checkpoint inhibitors, but we need to do more. We need to better understand how the immune responses are engaged and in which patients with which tumor related antigens. And so there is a lot to understand. We know that immunotherapy is working in lung cancer. We know that sometimes it is not working. It's very important to have a capability to predict, to stratify the patients for escalation with more aggressive treatment, meaning probably more efficacy but also more side effects, versus patients who are expected to have a good outcome with immunotherapy, that we can even desescalate and avoid those patients chemotherapy and treat those patients only with immunotherapy. So understanding the biology behind the efficacy of these drugs is crucial.
Absolutely. And this precision medicine is reshaping oncology care. What challenges and opportunities do you see in integrating genomic and biomarker driven therapies into the more routine lung cancer management?
Well, it's a matter of technology. There are new technologies that help to have this understanding. Single cell transcriptomics is a new era in the understanding of the interaction between cancer cells and immune cells. To understand the heterogeneity of cancer cells, it has been reserved for molecular basic science research for a long time. Now we know that single cell transcriptomics is feasible on specimens taken in the clinic, FFP specimens. So I see these technologies coming into the clinic. Again, it will take some time, but we need to generate some data that show how a deep understanding of the biology of the tumor, not only globally but at a single patient level, may help to predict the efficacy of treatment.
Mm. So, talking more on immunotherapy, it's transformed the treatment landscape for lung cancer. From your perspective, what are the current challenges and future directions in optimizing immunotherapy for different patient populations?
Well, besides the prediction of the efficacy, we need more immunotherapy agents. Nowadays, it's mostly PD-1, PD-L1, CTLA-4 inhibition. We know that the interaction between cancer cells and the immune systems involve more than 20 molecules that we need to use for the treatment of the patients. We know also that immunotherapy may be given as a single agent, but also may be combined with chemo and other agents, especially the antibody-drug conjugates. Very important also to use immunotherapy in non-metastatic disease. We have seen how the perioperative, the neoadjuvant immunotherapy has changed the natural history of the disease in patients with resectable non-small cell lung cancer. So there is a lot to do, but we cannot combine everything with everything. And again, the understanding and the biomarker identification is crucial to for the development of those strategies.
I'm interested because I know with the French, and do correct me if I'm wrong, but was it true, or is it true that 1 in 4 French adults smoke? And I know the government are bringing about public health measures to try and reduce that statistic. How, A, do you think that's a good idea? And B, how do you feel that that's going?
Obviously, it's a good idea. It's prevention, especially the increase of the cost of the taxes on cigarettes. But it's also a matter of lung cancer screening. Lung cancer screening is consists in doing CT scans, low dose CT scan to high risk individuals, heavy smokers. We know it works. We have several landmark trials that demonstrate the benefit in reducing the mortality related to lung cancer by 20%. So we know that lung cancer screening is working. In many countries, it is implemented, including the UK, in the Netherlands, Belgium, the US, Canada. France, it took a long time, but here we are. We have a national program that is now starting uh, to screen high risk individuals. We know that it works not only in reducing the mortality, but it works also to reduce tobacco smoking. So that's a very good thing. We have seen in the countries that have implemented lung cancer screening that we have a switch from a majority of patients diagnosed with metastatic disease to a majority of patients diagnosed with early stage. So this is the expectation for sure. And to me, it's one of the major challenge to integrate lung cancer screening in the healthcare system, in the French healthcare system, and we are also working on that. It's also a unique opportunity to assess the new modalities for lung cancer screening, including biomarker testing, blood sampling, assessing biomarkers that will help to predict the risk of cancer in individuals. So this is a predictive medicine, and I think it's very important to move into that direction.
Fantastic. So finally, if you had 3 magic wishes for the future of thoracic oncology research and patient care, what would they be? You can only have 3.
So I have a lot for sure. I think that better stratification of patient is crucial. It's impossible to escalate, intensify the treatment for all the patients, knowing that some patients do not require such aggressive management. So this is to me the major challenge, and I think this is achievable to have a better stratification of the risk at an individual patient level. The second thing is obviously to have better drugs and combination, and we see the antibody drug conjugate, the antibody bispecific antibody. Uh, Again, we will not be able to combine everything, and we probably need to to base a decision for a development on the biology. So we need to understand and perform translational studies pretty quickly, part of the early phase trials. And my third one is screening. Clearly, I'm a believer of lung cancer screening. It will completely change the natural history of the disease, the epidemiology, and also our practice.
Wow, wonderful. Well, thank you for joining us for this episode of Onc Now with Professor Nicolas Girard. If you enjoyed this conversation, please subscribe on Spotify or Apple Podcasts, leave us a review and share this episode with your colleagues. Until next time, stay safe, stay well and stay curious. Professor Girard, a real pleasure to have you with us. Thank you again for joining us for Onc Now.